Hello, good afternoon, everyone. I hope you all are doing fine. Today, we will have our presentation titled Pathways to Leadership, a showcase by the Behavioral Health Empowerment and Leadership Academy. Today's speakers are Nestor Acevedo, Mario Sayas, and our moderator, Diane Arms. You can use your chat and you can start by saying where are you located, where are you tuning in from, okay? To hear today's presentation in Spanish, please go to the Interpretation tab on your Zoom panel and click Spanish. You can also mute the English speaker's voice clicking Mute Original Audio. Para escuchar la presentación de hoy en español, vaya a la pestaña de interpretación en su panel de Zoom y haga clic en Español. También puede silenciar la voz del orador en inglés haciendo clic en Silenciar Audio Original. Next slide, please. During today's webinar. Now we will review a few housekeeping items. Today's event is being recorded and will be made available publicly through our websites and other media channels. For today's webinar, all participants will be muted. Please make sure your computer speakers are turned on, and up to hear today's presentation. If you are having technical issues, please send a message to the Hispanic and Latino Behavioral Health COE on the chat box. If you have a question for our presenters, we ask that you use the Q&A tab on the toolbar. Simply type your question and hit send. We can address questions to the presenter at the appropriate time during today's presentation or at the conclusion. We will be sharing a copy of today's presentation in PDF format through the chat box. We will also make a copy of today's presentation available to be downloaded through our website. You can find it under the name of today's event. A recording of today's webinar will be posted in our YouTube channel. Once we complete the webinar, we ask you to complete the evaluation. The evaluation will help us know more about your opinion and thoughts about this presentation and what other topics and training would you like to see offered. A link to the evaluation will be shared through the chat. You can also scan the QR code at the end of the presentation to complete it. Our mission is to advance and support the sustainability of behavioral health by promoting community-driven, culturally grounded, and person-centered prevention, treatment, multiple pathways of recovery, and recovery support for Hispanic and Latino communities. Also, we strive to accomplish this mission through the development and dissemination of culturally informed, evidence-based behavioral health information, providing training and technical assistance, and supporting the growth and expansion of the behavioral health co-workers that serve Latino communities. And now I will leave you with Diane Arms to continue the presentation.
Thank you, Angelica. So good morning or afternoon, everyone. My name is Diane Arms, as Angelica shared with you, and I have the pleasure of moderating this session for the Hispanic Latino Behavioral Health Center of Excellence Leadership Empowerment Academy. Before I get into what we are in store for today, I want to tell you a little bit about our Leadership Academy in general. Last year's Leadership Empowerment Academy, hosted by the Hispanic Latino Behavioral Health Center of Excellence, brought together a diverse cohort of emerging and mid-career leaders from community clinics, nonprofits, and public systems. Over a focused series of sessions, we built practical leadership skills through adaptive leadership, facilitation, and change management, while grounding everything in culturally responsive practice and the lived experiences of the communities we serve. For 12 months, participants worked on real organizational challenges, not case studies. They mapped stakeholders, clarified problem statements, and designed small, testable pilots ranging from improving client access and extending hours to reframing clinic language to reduce stigma and increase trust. They met with their mentors and colleagues monthly, and along the way, we emphasized data for learning, setting simple outcome measures, capturing community feedback, and using that information to iterate rather than to prove a point. What made the Academy special was the network it created. Leaders didn't just learn tools, they built cross-country relationships that have continued well beyond the program. Several projects launched during the Academy are now being scaled at a larger level. We also saw personal growth. participants reported greater confidence facilitating hard conversations, aligning teams around a shared purpose, and communicating change in a way that feels human and hopeful. In short, the Academy delivered three things: practical tools you can use, trusted peer network, and momentum for tangible improvements in access, experience, and outcomes. We're excited to build on the progress with this year's cohort and keep turning leadership into measurable, community-centered results. We're excited to be preparing for our second cohort that will kick off November 17th and look forward to even more growth and opportunity in our communities thanks to the Hispanic Latino Behavioral Health Center of Excellence. So on to today, what can we expect? We'll explore how two mentees within their respective organizations turn challenges into opportunities. First, by confronting stigma through a powerful reimagining of identity and language. And second, by expanding behavioral health access through the extended service hours. Both of these initiatives remind us that leadership isn't just about managing programs. It's about listening deeply to the community's needs, making bold adjustments, and ensuring services reflect dignity and inclusion. After both presentations, we'll open the floor for discussion to reflect on leadership takeaways and ideas you can bring back to your own organizations. Several objectives that we will have today are to explore leadership strategies and change management approaches, examine the intersection of culture, community context, and operational design, and then at the end, facilitate a dialogue on lessons learned and transferable practices. So, without further ado, I will introduce today's first speaker, Nestor Tommy Acevedo. LCSW serves as Administrator of Mental Health Services at Valley Health Partners Community Health Center. In this role, he oversees all mental health service operations, including integrated behavioral health and psychiatry. Across Valley Health Partners clinical sites in Allentown, Easton, and Poconos, Tommy has worked in the field of behavior and mental health for 15 years as a researcher, clinician, and leader, and he has been with Valley Health Partners since the organization's inception. He serves on the Pennsylvania Department of Mental Health Planning Council with a focus on improving access to and the quality of mental health services provided in the state. Tommy is passionate about addressing barriers to accessing mental health services and decreasing the stigma associated with seeking treatment, especially in traditionally underserved communities. Tommy is an avid aviator and enjoys spending time with his wife and 3 children exploring Pennsylvania's great outdoors. Help me welcome Tommy.
Wonderful. Thank you so much, Diane. Special thanks to the entire team with the Center of Excellence. It was an incredible experience participating in the first cohort and quite an honor to be here with all of you today. Thank you for taking time out of your day to join us. I'm very excited to share with you the incredible work that came out of this experience with the Center of Excellence and how that translated to the work that's being done here in our health center. So without further ado, I would like to present to you what's in a name, the cultural and operational impact of nomenclature on behavioral health stigma in a community. In terms of the objectives for today in my presentation, first, I'm going to provide some context. So I'd like to review some key differences between a quote-unquote traditional health center and a federally qualified health center. I'm going to provide an overview of Allentown's 17th Street community within which our health center exists and the history of the 17th Street, previously known mental health clinic. We'll then move on to review and discuss the clinic's transition and the 6-step process by which my project was conceived and implemented. We'll then transition to reviewing outcome data and discussing next steps. We'll review the leadership skills utilized throughout this project, and then review the community and organizational impact of the initiatives that were implemented. And then, of course, at the end, as mentioned, provide some space for questions and discussion. Next slide, please. Okay, so in terms of the differences between a traditional health center and a federally qualified health center, for those who may not be aware of the primary differences, I won't go through the entire slide, but the main talking points here are that, number one, community health centers are actually the largest network of health centers in the United States. We provide more medical care to more patients than any other type of health center or organization in the United States. We are, by definition, a nonprofit organization. Our board is actually, by law, required to be 50% made up of patients whom we serve. We receive federal grants and cost-based reimbursement. That latter point is integrally important to our model. We are able to receive a higher reimbursement rate from medical assistance programs, with the caveat being that that increased rate is going to go back into the health center and back into the community. Our mission is very much focused on providing care to those populations which are traditionally deemed as underserved, including those who are indigent, uninsured, and medically underserved. We do offer sliding fee scales based on income and family size, and we do not deny patients care based on their income, residency status, or insurance status. We pride ourselves on providing whole person care, which is not just specific to me in terms of behavioral health or medical care. We also provide social services. We have community health workers. We really focus on that whole person approach to care. Next slide, please. So, getting a little more micro in our view here, I'd like to welcome you all to Allentown, Pennsylvania. As you can see in the top left, we are in the eastern part of the Commonwealth, very close to the New Jersey border. As of the last census, the population was approximately 125,000 individuals. We, from a historical perspective, find it interesting that the Liberty Bell during the American Revolution was actually hidden from the British in Allentown from September 1777 to 1778. Most notably for my work and this presentation, however, is that we have a very large Hispanic population, primarily from the Dominican Republic and Puerto Rico, and that population has grown exponentially over the past 3 decades. At 12% in 1990 to almost 60% as of 2024. Also extremely important, 21.6% in Allentown live below the federal poverty line, which is higher than the national average of 12.4%, so almost double. And we can see here the two graphs showing not only the demographics, but also the growth of the Hispanic Latino population over time. Next slide, please. Focusing on the 17th Street Mental Health Clinic. This is one of 2 psychiatry clinics affiliated with the larger health network, which Valley Health Partners separated ourselves from in 2020, Lehigh Valley Health Network. The mental health clinic provided psychiatry services to this community for over 30 years. 58% of the patients have medical assistance as their primary insurance in this area. The clinic itself was comprised of 4 attending psychiatry physicians, 1 advanced practitioner and nurse practitioner. We also are a residency program. We have 6 resident physicians, 2 nurses, a case manager, and 3 behavioral health specialists. In the last fiscal year prior to the transition, the clinic completed about 5,500 visits. Now, below in these 2 pie charts, what's extremely important to note is let's look at the racial demographics in terms of the patient panel at the Center of Hope prior to the transition. This is the pie chart on the left here. What we can see is that the clinic was predominantly serving non-Hispanic patients, almost 73%, with the Hispanic Latino population being served at about 27%. And yet, I just reviewed with you the racial demographics of Allentown itself being primarily Hispanic. And so, right away, we're starting to see a problem here. And so if you would click one more time for me there, Diane. This was a really great snapshot of what I was thinking when I was taking on this clinic and also considering my project. Very clearly, this psychiatry clinic was not serving the predominant demographic of individuals who live in this community. And so it became very clear early on that my work was cut out for me. Next slide, please. In 2023, the discussions began with the larger health network mentioned to begin to transition the psychiatry clinic under the federally qualified health center. Now, to note, Valley Health Partners as an FQHC was established in 2020. So about 3 years into this new endeavor, we began having conversations with the network from whom we split about the psychiatry clinic itself. And what we recognized was, again, we exist in a community which is predominantly Hispanic Latino, and that those particular community members are insured via medical assistance predominantly, and they are also disproportionately impacted by social determinants of health and health disparities. When we began discussions prior to the transition, we made sure to include clinic staff, leadership from the previous network, and patients. The reason that is in bold will be highlighted later in the presentation, but the importance of it must be established now. We wanted their input about this transition. We identified barriers that needed to be broken down, and patients with medical assistance would now be able to receive services closer to home. The transition to the federally qualified health center would allow those patients who predominantly lived around this clinic to actually be seen. We also recognize that the name itself, the mental health clinic, was perpetuating stigma within the community and creating and reinforcing barriers to care. And so on December 9th of 2024, the 17th Street Mental Health Clinic formally transitioned to Valley Health Partners and became what we now refer to as the Center of Hope. Next slide, please. When we talked about the 6 steps that were identified in my project related to the transition of the clinic itself, we're gonna go through these together rapidly. First and foremost, we recognize that the prior focus on serving patients in the clinic who had insurance, specifically commercial insurances, did not allow the community who predominantly existed around this health center to receive services since they predominantly had medical assistance. Furthermore, the referral and scheduling processes that were in place were creating barriers for community members to receive care at the clinic. The reason being that there were exclusionary criteria within an embedded algorithm which considered insurance coverage, residency status, geographic location, substance abuse history, all as eligibility criteria. These services were targeting patients with commercial insurances who, without question, had higher incomes, allowing them to pay for those insurances. We also recognize, as mentioned, that the mental health clinic name not only created but perpetuated for decades a stigma within a community that is already disproportionately adept at stigmatizing mental health and behavioral health treatment. And just important to remember, one of the driving components to not only my desire to move ahead with this project, but recognize the community within which we serve, is that research shows that many Caribbean cultures place a very strong emphasis on the value of self-reliance and the belief that higher educational attainment increases an individual's risk for mental health concerns, meaning we don't talk about this. If you could click one more time, please. Immediately, we started to recognize the work that needed to be done. First and foremost, as mentioned, in terms of insurance coverage, well, the research shows that in 2022, almost 17% of Hispanic and Latinos lacked health insurance in the United States, compared to 5.3% of non-Hispanics. And furthermore, in terms of the name itself, that stigma, in 2023, Hispanic adults were 60% less likely to receive mental health treatment than non-Hispanics. Next slide, please. Next step, the consideration of our interventions. We must remember that the research shows quite clearly that Latinos report lower rates of mental health service utilization compared to non-Latinos. Some of those are related to language and cultural barriers, including English proficiency directly correlates to reduced access to mental health services and poorer outcomes in centers which don't recognize the importance of ensuring that services are in the patient's native language. We also recognize that Latino communities in particular often experience higher exposure to stressors, which elevate their risk of both depression and anxiety. And yet, if we go back to the first point, they are utilizing mental health services at a lower rate. Something is going on here. So what I also recognized very early on in the project is the need for a collectivistic approach to how we intervene. This was not going to be Tommy dictating what is going to happen. In fact, it was my role to be a coalition builder and to include not only members of the clinic and those who have been there for decades, but our community. That is incredibly important. We needed to have a team mission to dismantle systems that contributed to these disparities. Next slide, please. In terms of my initial conclusions, we recognized again that the clinic was previously targeting patients with insurance, as under the previous model of care, this was financially advantageous for the previous network. They were not receiving the higher reimbursement rate for medical assistance, so they targeted those patients with insurances that would deem a return for them to keep the lights on in the clinic. We also recognize that there is an immense opportunity to provide community-based healthcare to a traditionally underserved population. And finally, the name, it had to go. Next slide, please. The third step in this process was the identification of our action items. First and foremost, as mentioned, we needed to change the name with a focus on community, colleague, and provider input to reflect the center's mission. Remember, leaders need to use a collectivistic approach to work with the public sector to address disparities and inequities. Next, we needed to shake up the existing systemic barriers. Initially with the centralized intake department, this was the department that was deemed the task of utilizing that algorithm to determine who would be eligible to receive services. Remember, a team mission to dismantle systems that contribute to disparities is key. Third, we need to focus on how we were marketing to the community who we were looking to serve in order to increase access to services and ensure that we were truly speaking to the community. Finally, maintaining consistent communication with the community, the leaders, and clinic staff was critical to ensuring the not only initial buy-in, but eventual accountability and success of this project. Next slide, please. So it was time to take action. And as mentioned, the first step was changing the name. And so, utilizing that collectivistic approach, we surveyed both patients from the clinic, members of the community, and staff. I will readily admit I had absolutely no initial input in the renaming of the clinic. This was completely organic from the community and the incredible colleagues who worked in this clinic who were eager to have the name reflect the mission and to open those doors to the community within which we exist. And so we transitioned away from the mental health clinic to the VHP Center of Hope with a specific consideration of how that name would translate into Spanish. Second, in terms of the centralized intake department, 3 months prior to the transition, we shook it up. We removed all exclusionary criteria based on financial, insurance, or residency status. We created new workflows to ensure that patients that are being scheduled are from this community. We prioritized patients whose primary care clinics were in our hospital and within this community, and specifically those with medical assistance. Finally, we made a very concerted effort to ensure that our scripting, the marketing that we used, and the way in which our colleagues interacted with our patients were culturally sensitive and appropriate to the individuals whom we were serving. We ensured that we reviewed and amended any language which created or perpetuated stigma in the community. We wanted to ensure that we were truly speaking to our community. Next slide, please. In terms of taking action, some more items here, specifically the marketing and communication with our community. These are actual snapshots here of our new marketing materials. We wanted to move away from language which could further stigmatize our community. We recognize that previous marketing materials specifically utilizing language like depression, anxiety, specific symptomology was language which was a barrier to patients wanting to seek care, and specifically in the Hispanic and Latino communities, in which these are very triggering words. And so we decided to approach it in a very different way. And so instead of language such as, are you depressed? Are you anxious? We changed it to, need to talk? Are you feeling stressed? We recognize that this simple change in language makes the approach or desire to approach us for services much more palatable and culturally sensitive. Also, very important to point out that even just the individuals and the posters themselves did not previously reflect our community. Finally, we recognize the importance of appreciating when patients did want to engage us with services and ensuring that they felt comfortable doing so. This is our example of the Meet Your Provider face sheet. So any patient who schedules with one of our therapists will receive an individualized face sheet with the provider's name, their primary areas of focus, their interests, and as well as just information about the services to be received to further reduce that stigmatizing language, and in hopes of connecting our community with language which is not as stigmatizing and which makes them want to move forward with receiving services. Next slide, please. So we put these into place, and of course, we need to measure the outcomes. Within the first 5 months of the go live at the Center of Hope, we saw an immediate change in terms of our medical assistance payer mix. We saw a 17% shift from commercial payers to medication assistance, reflecting a notable shift in the number of low-income patients being served. In a very short period, we began to see the patient demographics in our psychiatry clinic more accurately reflecting the community within which we exist. We also specifically saw a 3% increase in the number of Hispanic Latino patients receiving services in the clinic, which, when we consider the current environment within which we exist, this is a very significant increase and one which we are extraordinarily proud of as an organization. Next slide. In terms of qualitative analysis and data, this is a graph representing what is known as the NRC patient satisfaction scores. After patients receive services in our clinics, they are surveyed either telephonically or via a text message, where they can provide their feedback as to the quality of services they received with specific questions related to cultural competency, approachability of providers. And what we saw is, since the acquisition, the satisfaction with the services being received in the clinic increased by almost 17%. Next slide, please. So what's next? Well, we continuously monitor our visit data and those patient satisfaction scores. Since the December 9th transition, we've completed over 5,000 visits in the clinic. Now, mind you, the previous fiscal year in total, the clinic saw 5,500 patients. And so since December alone, we've nearly hit that metric. And this is a testament to, despite the current environment within which we live, more patients from our community are now seeking traditionally stigmatized services. We're going to be starting patient-centered focus groups, and these are actually going to be starting in the next few months here to gather direct feedback from patients regarding the services rendered and areas of improvement. The NRC scores are great. However, I don't know about anyone else in the call here, but if I receive a survey via text or a call, my likelihood to engage in that is a bit lower. Now, that being said, I do need to ensure and plug here that all of you, please complete the survey at the end of this discussion. That being said, we recognize that as a culture and a community which appreciates gathering and communicating in a safe space, we as a health center are obligated to provide that safe space to discuss a traditionally stigmatized topic, to identify areas of opportunity, as there always will be. Remember, cultural competency is always a linear progression. There is no end point. We should always be considering what we can do differently. Specific to our community that we were are serving here, and I must give a shout out to my mentor, Germán Cadenas, who suggested the implementation of cafecito groups, right? To be started with our Spanish-speaking patients to, again, garner that direct feedback about the services and ways in which we can engage with the community in a more culturally sensitive way, which recognizes and directly combats the stigma related to mental health and mental health treatment in our community. We're focusing on also ensuring that we offer virtual visits to those patients who may be concerned about coming to our health center within the current political climate and environment. The patients are not comfortable with coming to see us. We want to make sure that we're going to them. Finally, a men's-specific support group. One of the things that the data in our health center shows is that Hispanic Latino men in particular tend to seek and receive behavioral health services at a lower rate than our female counterparts. And so we would like to understand better as an organization as to how we can engage with our community in this way. And so creating men-specific support groups with no language specific to mental health or behavioral health, simply a space within which we can gather with our community peers to discuss barriers to care or what we can do differently to serve the community. Next slide, please. So in review of the leadership skills that were utilized throughout the project, and to get us to the point that we are, first and foremost is, of course, cultural awareness and education. And the importance of this cannot be understated. It's one of the most critical components to not just the project, but the work that we're doing moving forward. Ensuring that we learn a better understanding of what this looks like from the community, from our patients, from our colleagues, and to ensure that these conversations always referred back to the prevalence of stigma related to behavioral health services in our community. Next, analytical skills. The utilization of both quantitative and qualitative analytical skills were crucial to the project's success. The numbers don't always tell the story, and nor do just the stories from our patients tell the story. It is the synthesis of both, which highlights not only the initial need, but now the success of this intervention moving forward. Teamwork, critical to everything that we have done and continue to do. Relationship building skills were used initially, again, to partner with colleagues in the Center of Hope, but also as importantly, if not more so, our community and those patients who we serve. Coalition building was critical, especially when working with Lehigh Valley Health Network's Department of Psychiatry. We needed to build a lot of bridges before we shook up the system. Finally, strategic planning. There will be ongoing analysis of the data, both quantitative and qualitative, to determine any operational or organizational changes which may be necessary to improve the outcomes of this project and all of the initiatives associated with it. Again, we recognize this to be a few steps forward, but the work is certainly not done. And that strategic planning, openness to critical conversations internally, but also with our community, is what will ensure that we not only maintain the motivation and success of this project, but also further connection with our community moving forward. So in conclusion, let's review what it is that we set out to do and whether we achieved it. Did the change in the name and rebranding of the clinic have a positive impact on visit volumes? It sure did. Did the rebranding and psychoeducation on stigma increase the number of Hispanic Latino patients seen? Did we finally start to serve our own community? We did. Did the collective leadership approach, which Mario and I were fortunate enough to spend a lot of time being able to engage with incredible mentors and colleagues, positively impact my project and his, but also the processes there within? Absolutely. Did we identify areas of improvement to continue to address the stigma related to mental health services in the community? Absolutely. And the work continues. With that, I want to thank you all for your time. It's been a pleasure, and I'll turn it back over to Diane and my good friend Mario. Thank you.
Thank you, Tommy. What an amazing presentation. And I'm just so proud of the growth that you've had throughout the year. I was fortunate enough to see both you and Mario just become even better leaders, stronger leaders, and such an asset to the Latino community. So, if you have any questions for Tommy, we'll open it up at the end. But first, we are moving on to Mr. Mario Zayas, a bilingual licensed marriage and family therapist at San Isidro Health in San Diego, California. With over a decade of experience providing behavioral health services within multidisciplinary teams. Since joined Sci Health in 2015 as a family therapist for Behavioral Health Department's Youth Enhancement Services Program, a County of San Diego HHSA funded initiative offering outpatient mental health and substance use services to youth and families, he has demonstrated a strong commitment to integrated and community-based care. In 2020, he transitioned to the role of program manager for SY Health's Certified Community Behavioral Health Clinic program. For you all that know the CCBHC, collaborating with leadership to establish and integrate the program within the organization's federally qualified health center structure. His extensive experience spans direct clinical service delivery, behavioral health program management, coordination of care, and SAMHSA grant oversight. Through his leadership, he has guided the development and implementation of the CCBHC program, ensuring high-quality, accessible behavioral health care. Driven by a passion for empowering individuals and communities, he remains dedicated to advancing the integration of behavioral health and primary care services. Please help me welcome Mario.
Thank you, Diane. Appreciate it. And thank you, Tommy, as well. So, I'll go ahead and introduce myself. Mario Zayas, LMFT Behavioral Health Senior Manager at San Isidro Health. At San Isidro Health, we are just a little bit of an overview. We are a federally qualified health center, FQHC, which Tommy did a wonderful job at describing what that was in his initial slides. So I won't go into and repeat that information, but at San Isidro Health, we're a nonprofit organization. We're committed to improving the health and well-being of the communities we serve with access for all. That is our San Isidro Health mission statement. As an organization, we have multiple departments where we provide community access to comprehensive medical, dental, and behavioral health services, as well as support services and programs that help with other needs like food, housing, and health education. So specifically within our behavioral health department, the services that we provide child, adolescent, adult therapy and psychiatry. We provide addiction medicine services provided by our addiction medicine doctors. We also have substance use disorder counselors that that is also included in our substance use services. We also have a nursing team dedicated for our behavioral health department, and they focus on mental health triaging and crisis and injectable medications. We have a large case management team as well and peer support services. And those case management services and peer support services are really crucial and essential to the work we do in driving the clinical services that mentioned in the top slides. So next slide, please. And what I'm doing right now, I'm just setting the stage for how and the things that were considered as we throughout the journey in identifying my project for when I'll participate in the Leadership Academy in the past year. So currently within our San Ysidro Health Network, we have 18 clinics that have behavioral health services. And on the left, that table just shows the different clinics where we have behavioral health presence and our behavioral health services. And on the right, that is the new programs and expansions that we went through since 2020. So since April 2020 through 2025, those are the various different programs, clinic expansions, whether the expansions were expansion of services or some of them were expansion of locations where we then opened up some clinics in the rural areas of San Diego. In 2023, we also, as a department, started expanding the scope of services and the age range that we reach within our community. So we did have the services that we provided to our youth. However, we expanded that team and grew it to be able to reach the community on a higher level as well. And then leading to 2025, we are in the middle of some other expansions that are planned for the last couple months of the year. So expansion continues, and it's just something that we adapt and grow within our organization and in the community. Next slide, please. So in terms of since 2020, I just my last slide had the growth of our services and location and department. In terms of staffing and our workforce, since the end of 2022 through the end of 2024, a lot of our clinical team and our support service team has grown immensely. Some of them almost doubled. Our case management team definitely doubled. We do have increased number of psychiatrists, therapists ranging from licensed therapists to associate therapists that provide services under the supervision of a licensed therapist or a licensed provider. And then so a big part of our services also are medical assistants as well, because they the medical assistants and the case manager team, although they are not like the clinical providing they're not rendering services that are billable within our network. They definitely are roles that help drive services from start to finish within our department. So that is one that we wanted to make sure that as we grew our clinical team, our support services grew hand in hand with that and in a sustainable way as well. Next slide. So a little bit going into CCBHC services. So CCBHC, as I mentioned, it stands for Certified Community Behavioral Health Clinic. And we rolled out our CCBHC services within our San Ysidro Health organization in 2020. And initially, what led to that was just the nature of how our services in our communities are provided. So as you see in this graph with the arrows, it goes from the green to the yellow to the orange to the red. So the healthy and all the way through severe. Historically, within our FQHC services, we're set up to serve the mild to low moderate levels of needs, including the healthy as well. And in the past, prior to our CCBHC services being integrated within our organization, when we would encounter situations where a patient needs a higher level of care, we would historically refer out to the community, which we continue to do so, and definitely is a great fit for many community members seeking services. However, there are also a group of members that and patients that receive services with San Ysidro Health that really trust the services that our organization provides. They've been with the organization, or they've been receiving services for many years, and their family members, so they at times were reluctant to seek out services externally outside of our organization. And so a lot of times when we would refer out to community programs, months later or after some time, those same individuals would come back to seek behavioral health services with us, and we would assess, hey, how did things go? How did things go with the program that we referred you to? And outcome was a lot of times it was didn't go, but I didn't qualify, I didn't feel comfortable going. Can I please just receive services here? So the moderate to severe services, or services that meet those needs, was definitely a huge need for us, and that is what prompted us to expand our behavioral health services to provide higher level of care services for our behavioral health department. So next slide, please. And in terms of CCBHC, one of the things that we really were fortunate enough to implement was an integrated approach to really address the whole person when they're coming in for services. So as I mentioned initially in my earlier slides, our organization, we provide medical, dental support services, behavioral health services. There's an array of services that our patients receive within our organization. So having now additional services within our CCBHC to meet the moderate to severe levels of need allows us to transition from the top arrows, which have gaps in between the health and the mild to moderate, and moderate to severe. It allows us to render services that are more aligned with the bottom arrows, which is more of a continuum from the green to the red, because as we know, as life circumstances happen, one day things may be going well, the next day maybe having a more challenging time, and having all these services under one organization and one network has been, it's been a huge support for our community, because there's just it's easier to collaborate amongst our medical providers, with our psychiatry providers, with the therapy providers, and our patients in our community know what to expect, because it's still all under our San Ysidro Health umbrella and organization. Next slide. So in terms of specifically with our CCBHC visit numbers, which is the program that I'm a part of, and as I mentioned, this is our higher level of care program within our department. So we have also dealt with a lot of growth. On the left, those were our staffing size at the end of last year. And on the right, these were our visit numbers from 2020 through 2024. So one of the things that I did want that I'm highlighting here is just the immense growth in staffing, but also in the services that we provide to the community, which has led to increased visits. When I see increased visits and I hear increased visits, what I think of automatically is increased access. So access to our community has always been a priority for myself and the organization. As I mentioned, that's part of our mission statement for San Ysidro Health. So we went from 2020, when we initially rolled out our CCBHC program, for 509 visits to end of 2024, where we had 13,843. We will obviously continue reviewing our 2025 data at the end of the year as well. But I can assure you those numbers and the growth has continued. So that led me to thinking throughout my journey in the Leadership Academy. When we started initially, I worked really closely with my mentor and also with our cohort with the other participants in Leadership Academy, and seeing how are others addressing their project. One thing that was really important for me was I wanted to identify a project that was going to that had the potential to have multiple ways of impact. So there's two things that I really had in mind: access for our community for services, for behavioral health services. So our patients is one. The other one was our staff, our workforce. Those two are the two things that I wanted to make sure were included in the project that I identified. So next slide, please. So through talking and through this Leadership Academy, what this led me and helped me and supported me with personally within my role at San Ysidro Health, it created a platform to discuss potential opportunities for growth and improvement of services or improvement of the model, our staffing model. And it just led me to have that platform to be able to have these more in-depth discussions and with our San Ysidro Health leadership within our department, our director and our chief of our department. And it allowed us to kind of brainstorm on what are the different areas. So initially we thought, well, we can expand services and create something evidence-based group or practice and to address this area. But for me, I wanted to have something that involved the community and our workforce. So expanded hours. That topic was a topic that had been brought up in the past, but we weren't at a point like in 2021, as you see, since we've had a lot of growth since then. We weren't at a point at that time to really pursue that expansion of hours. So now that when we were discussing this, like, hey, what can we potentially work on? Expanded hours resurfaced, and that is one that really it just stuck with me right then and there when it resurfaced through our collaborative discussions. And I thought, yes, let's run with this. So the reasons why is now with this, we can increase the amount of patients and clients that can remain in-house within our San Ysidro Health organization. And because one of the challenges we have was we have patients seeking services and they work, adults work, children go to school. So during our normal office clinic hours, 8 to 5, they weren't able to attend services during those hours. So when that would occur, we would have to refer out to the community. And as I mentioned, we still do. However, there were groups of patients that we referred out that really would have a preference to stay with our organization and with San Ysidro Health, which they are familiar with. So this now will allow, it will increase access for that group of community members that can't access services during the 8 to 5 traditional hours. And essentially it improves overall access to behavioral health services for the communities. And then also the workforce aspect of things, it will offer flexible schedule options for our employees. So this would have a huge impact for employees with longer commutes. And then it also offers alternative options for employees with families that they may need to attend a school meeting. They may have appointments that they need to take their family members to. And then it also increased opportunity for workforce development because we then are able to, it has the potential to we're able to reach another group of people who are interested in working with us that may need to have a later start, or may just need to work different hours than the 8 to 5, and it just provides a little bit more of a flexible approach that we can take there. Next slide. So here's just some additional information on the potential benefits that we are expecting to see when we go back and reassess and analyze how this has really impacted. So less commuting time per week for our team members. And then some research suggests that there's increased productivity and relaxation on the workforce side of things. So more focused and efficient with longer, more structured work days and a 3-day weekend to recover. Other pilot programs in public agencies reported equal or greater output despite shorter work weeks and improved work-life balance. The reason why workforce was a big component that I wanted to make sure was included in my project was because obviously the workforce we need our workforce to be in a good state to be able to provide high quality level of services, and the community, of course, we want them to have access to services as well. So the reason why the productivity portion of things came on what we needed to make sure that was included was because one thing that we really needed to consider before we even went any further in the project was how can we still maintain this from a sustainability portion, and we needed to make sure that our productivity was not going to be negatively impacted because, of course, these are revenue generating services, and of course, lights need to stay on. So what we needed to do as we were approaching this, I needed to pull the information on our daily productivity, weekly productivity, and then also we needed to, for the productivity portion of things, identify how that would look with the different work hours. So that's one of the things that could not be ignored, that needed to be considered as I was approaching the project. Next slide. Okay. So other potential benefits for employers, there's less absenteeism and less use of PTO because now they have additional time during the work week to attend their appointments, attend meetings that they need to attend to, other life things outside of work. Also, 4 days, 10-hour work schedule provides 52 extra days off per year, apart from weekends, which employees can use to visit personal appointments, unrelated work things, and do things that they need to get taken care of outside of work. Also assists with recruitment because now increased hours and different flexible schedules potentially, and then improvement in employer retention because there's an interest in moving towards the 4-10 work schedule. From a group of our already existing staff members, and then also could eliminate some attendance punctuality for employees that maybe need to do school drop-offs in the morning for their children, but they still need to be at work at 8 traditionally. However, if we're with the later hours, now they can have a later start time, and that just reduces overall stress, therefore addressing the work-life balance portion of things. Next slide. Okay. And then here's just some of the initial schedule alternatives that we developed because expanded hours, that obviously is the overall larger goal, but we really needed to get down to the nitty-gritty on what would this even look like. So the first thing that came up was 4 10-hour shifts, work weeks. And then the other thing that came up was the second and the third bullet there, Saturdays, 8 to 12. So we do have already existing clinics that are open 8 to 12 on Saturday, that we don't provide behavioral health services during those clinic hours and at those locations on Saturdays 8 to 12. However, we identified that as an opportunity to not having to open up a whole new clinic, or a clinic that's not already that's not already open on Saturdays. Now open that clinic up. We're going to be starting out with that first. And then once we show with the data and the outcomes that it is a sustainable approach, and also the patient satisfaction and provider satisfaction also is aligned with that, then that'll allow us to take it to the next step of seeing which other clinics can we potentially approach here. Also, the 2 clinics identified for our initial launch were clinics that are already open later hours, specifically providing medical services. So we're using those clinics that are already open up later hours, and now seeing how we can incorporate our behavioral health services in those settings, as opposed to expanding hours for clinics that don't have later hours. So that'll be our next step once we show that it is sustainable and the outcomes reflect that. Next slide. So needs. We really needed to identify all the needs as we approach this. So of course, visit projections was a big component because revenue generating services is something that could not be ignored. So that was one of the first things. Next things was staffing. What is the bare minimum that for our pilot that we need to identify? Safety considerations, if there's a crisis, if there's a medical emergency, anything that could come up safety related, we also needed to make sure that that was taken into consideration. Security, which goes into our safety as well. Workflows. So workflows during the 8 to 5 hours also would vary during the later hours or even the weekend hours, because what's available during the 8 to 5 hours may not be available between 5 to 8. So need to identify, if a need comes up, what are the alternative services, or what are the processes to make sure that we address the situation if the things available from 8 to 5 are not available during those other hours. Designated parking for later hours. So because obviously for providers that are leaving later and it's darker, we want to make sure that they have closer parking and not park far away and need to walk in dark areas. Transportation. So a lot of our patients do use our transportation services, whether through their insurance or transportation options provided through our support services. So that's also something that needed to be considered, because sure, we can offer office appointments. However, if our community members can't travel or don't have a means to get to the appointment, that is also something that needed to be considered. Which programs were we going to identify? That's also something. So we did identify our higher level of care programs, so CCPHC being part of it. And just the last 2 slides that I have already spoke on. Next slide. And then these are just the bare minimum that we identified to start with. A psychiatrist, therapist, PSR, patient service representatives, case managers, medical assistant, and then of course security, which is already identified in our current clinic setups. So these were the things that we identified, and we're going to be rolling out with as well. And due to some internal transitions and some sites opening up, we had to delay the rollout of it. But however, we do have the methods of how we're going to analyze and see, compare the outcomes from the baseline from start to the 6 month, to 6 months to a year, and seeing what those differences are, and then continue expanding as we identify this. So, and then next slide, please. think that was my last slide. Yeah, so just last thing, just to mention in terms of the Leadership Academy, it really did help provide that platform to be able to have discussions, have these brainstorming sessions with our leadership and our internal team and internal key stakeholders. And then also, as we were working through that, through regular meetings with my mentor and through the support that we had with our amazing cohort, we were really able to work out some of the challenges and brainstorm and come up with our projects. So thank you to the Leadership Academy, Diane and Tommy.
Thank you so much. What an amazing morning, afternoon, whatever time frame you're in. We know we have people across the country with us. So we do have a couple questions that I received in the private chat, but please feel free to either put in the regular chat or directly chat with us if you have any questions. So I'm going to ask our wonderful panelists a couple questions. Again, if you have any, just go ahead and put them in. So the first question is, how did you ensure leadership buy-in?
Personally, on my front, I wanted to make sure that it was a collaborative approach. I wanted it to be something that was meaningful for myself, but would also be of value for our department, our programs, and as I mentioned, for our workforce side of things, but also our community. So that's how I approached it. And I made sure it was a collaborative approach to help with that buy-in.
Awesome, thank you. We know that research shows if you don't have buy-in, your project oftentimes fails. What about you, Tommy? What could you say about the buy-in from your leadership?
Sure. So, I'll preface my answer by just restating what I had mentioned a lot in the Leadership Academy is, as Diane had mentioned, it was a cohort of individuals in very different spaces and leadership positions. And so I was very, very fortunate that in my position, I report directly to our chief operating officer. And so in terms of, how many layers of buy-in I needed to navigate, it was fairly minimal. Now, I'm also very fortunate that our chief executive officer and chief operating officer are both Latinas from the community. And so, for me, it was much less of feeling as though I needed to sell this idea and more about recognizing that we all share the same mission and that I was simply proposing to them ways in which, as an organization, we can more effectively achieve that mission by, instead of telling our community what we as a health center think that they need, engaging them in conversation and asking the question of what they want. And when I had that information directly from the mouths of those we serve, I really didn't have to sell anything. And so I felt very, very fortunate to be able to say, again, this is the importance of quantitative and qualitative. Here's the stories from our patients. Here's the data showing why we need to do this. Putting the two together and utilizing the language of opportunity and less of business, it was quite easy for me in that sense. For those who don't share that same situation, I would encourage them to consider the importance of a servant leadership approach to things, which is to say, let's put on our glasses with the lens of opportunity. And also, instead of saying what's wrong or what we don't have, what's working and what do we have to then help propel us towards those goals.
Great advice. And I think I was so excited to get to the questions. Y'all, don't forget to fill the evaluation forms out. This is what helps us provide these webinars at no cost to you all. So I'm going to leave those up while I ask these couple other questions. Again, if you have a question yourself, feel free to put it in the chat. Tommy, I believe this one is for you as well. So how did you, speaking about that engagement of the community coming back and telling you what it is that they need? Oftentimes as Latinos, we kind of always like we put our head down. We, we don't want to fill out a survey. I think you even mentioned it in your presentation, right? So how did you engage them, and how did you get that data from the beginning?
It's a wonderful question, and thank you to whoever asked it. What we recognize is that oftentimes, no matter the size of the organization, to make substantive change that identifies community needs, we need to be patient and conservative. And what we recognize is that sending out a blanket survey to the community would achieve nothing. We've done that previously, and the return is very, very low. So what did we do? Well, I engaged all of our clinicians and staff who specifically interact with patients in the moment that they're seeking care to ask the question then. So instead of sending this blanket result out, knowing that we're not going to truly engage with the community because of those very same reasons, let's ask the questions when they're coming to us for care. So whether that's in a primary care visit, we would administer just 2-3 question surveys right there, very generally about how the community felt about mental health services to begin with, what their belief was about the importance of them, and then thirdly, did they feel as though they were comfortable with engaging with those services in the primary care space. And so it's another reality. We recognize that if we try to engage with patients and ask these questions in the primary care space, that's what was most effective because our patients feel comfortable seeing their physicians. And so to have these individuals who already are really critical components to the community, who a lot of these individuals who were uncomfortable talking about behavioral health would have these conversations with their doctors, that's who we utilize to then start to engage patients to ask these questions and also get the responses. And so we would always, of course, engage in informed consent and, make patients aware that, this information was going to be used to change the services provided. We were very mindful not to use the word improve, but simply to change. And so recognizing that it's going to take time. It's going to require a lot of rapport building with the community. And most importantly, you may need to identify and speak specifically to what you were doing wrong, which disengaged the community to begin with, before you can then move forward with getting their buy-in and desire to improve programs. We have a lot of individuals who are engaged right now providing feedback who don't get behavioral health services at all, but they are absolutely motivated to tell us how we could better engage with individuals who would want to. And so that's the piece where there's no books out there that can capture this cultural education and knowledge. So it's really about, again, the patience and being willing to try different approaches, because if a traditional approach isn't working, if you're unwilling to consider why it isn't working or unwilling to consider how you might change it with the input from the community, you're just going to run into the same lack of responsiveness and problems that you have historically.
Thank you for that, Tommy. I know that in my experience in the 15 years I've been in the behavioral health field, that client-patient feedback is so critical when making changes. And so I appreciate your feedback. So this is a question to both of you. Also, lots of great presentation comments. So kudos to you all. If you could go back and give yourself advice at the start of this Leadership Academy, what would it be?
It takes a community to serve the community. And trying to make substantive change by yourself will always be a losing endeavor. And so recognizing, again, being patient with the process and the need to engage both sides of things, meaning the leadership, who we need that, as we talked about, buy-in to actually implement services, but also the community. That's the foundation upon which we as leaders need to stand. And I don't mean stand above, but stand with. And so I would say for me, it would be to take a pause at the very beginning and to take it all in and to recognize that while it may be my project, that's simply the name on the first slide of the PowerPoint. The reality of all of this and the success that it's garnered is completely dependent on engagement with everyone that I mentioned. And so, regardless of whose name, is on the project itself, look to see who you have around you, including those individuals who you feel might be a barrier to progress. Oftentimes we find ourselves nervous or unwilling to engage with them. And oftentimes it's simply about changing the approach, the way that we speak to them, to break down that particular barrier. And so I think having that strengths-based approach and recognizing that one person's barrier is simply another person's door waiting to be opened.
Thank you. And that collectivist approach that you're talking about, definitely very familiar with that within our community, right? We like to do things. I mean, our parties are big, our dinners are big, our pachangas are big, all of it, so making sure that everybody's seated at the table. What about you, Mario? If you could go back and give yourself advice at the start of this academy, what would it be?
Yeah, so a couple things come to mind. The first thing is kind of along the lines of what Tommy was mentioning. From my experience, I would tell myself initially, this is not just a you project. It's more than just you. Don't try to take this on yourself. Because I remember really early on, I would, have these discussions with my mentor. I want to do something that really means something, like to me, and that also has the potential to create an impact. And I specifically remember, being told you do, the passion for sure is there. However, this project is not going to play out just with your efforts alone. And so identifying who are going to be the key stakeholders with whatever project you decide to roll with within your organization, and also you have your community within your organization that you work in. You have your network, your local network, whether it's within or outside of your organization, but also your support within the cohort and the leadership academy through the mentors, and even through the other mentors that are your identified mentor. There's just all that support, and what you think may be just be a unique struggle or like a challenge that only like myself was dealing with, the likelihood is other people have either dealt with something similar or are dealing with it. So might as well engage all the support and your network, local, within the cohort, wherever it may be, to brainstorm and bounce ideas off of. The other thing is also just recognizing that the way you envision the project day one may be different halfway down the line or at the end of things. Unforeseen circumstances come up, changes come up within the organization, within the program. Things just come up, and being adaptable and flexible it just goes a long way, because life happens and things are out of our control. So how are we going to respond to it? Not react, but respond to it.
Great advice for life in general, Mario. Okay, a final question. One word to describe your experiences with our Leadership Empowerment Academy.
I'd say inspiring.
Well, thank you.
Yeah. The two words came up. Tommy said my first one.
I'll give you two.
Tommy already said my first one, so I'll go to the other one. And it's in the name of the academy itself, empowering.
That's so great to hear. As I stated earlier before, we have started our interviews for our cohort 2. Our cohort 2 will kick off on November 17th. We're very excited Thank you to our presenters for sharing such thoughtful and inspiring work, and to everyone here for engaging in this important conversation. Both of these projects really illustrate how leadership rooted in collaboration, cultural awareness, and responsiveness can transform not just programs, but entire communities. As we continue this journey through the next cohort, I invite each of you to reflect on how you can lead change in your own spaces by naming challenges honestly, extending opportunities for access, and centering compassion in every decision. Again, thank you to the Center Hispanic Latino Behavioral Health Center of Excellence for putting on these amazing webinars. If you need to contact us, here are our handles, our website, and our email. We do provide, as Angelica said, technical assistance. And if you're interested in learning more about the Leadership Academy, please don't hesitate to contact us. Again, thank you everyone for your time. We look forward to the next one. Have a wonderful day, everybody.